Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast. In this episode, we will continue our exploration of Huntington's disease. In this episode, I'll be speaking to Thomas Bird, author of the book, Can You Help Me?, to further explore both dimensions of the disease. Thomas Bird is Professor Emeritus of Neurology and Medical Genetics at the University of Washington in Seattle. He was previously Chief of Neurology at the Seattle VA Medical Center and founder of the Neurogenetics Clinic at the University of Washington. He was also former director of the Huntington's Disease Center at the same university. Thomas Bird, thank you very much for accepting my invitation and welcome to the Neurology Lounge podcast.
My pleasure. I'm happy to join you.
Thank you. My usual first question is, why did you write the book? What was the inspiration for writing the book?
Right. Well, there are actually two reasons that I wrote the book. The first was I think this disease, Huntington's disease, is truly a remarkable disease. It's remarkable in terms of the manifestations it has in the patients, the effects it has on families, the effects on the community. It's almost unique in terms of all the various aspects of the disease. And in addition to that, it's an important disease, although it's relatively uncommon. It has overlaps with much more common and important diseases like Alzheimer's and Parkinson's and ALS and schizophrenia. So I think it's a fascinating and important disease. I think it's under recognized by the general public. So I wanted to bring the disease and its many manifestations to the attention of the general public.
Okay.
That's probably the main reason I wrote the book. The second reason, however, was that a few years ago, I retired and I had spent more than 40 years taking care of people and families with Huntington's disease, and it was an amazing experience for me. As you can tell from the vignettes in the book, they're very both interesting but difficult patients to evaluate and manage, and in some cases very trying on the team that's caring for them. And I realized that when I retired, I couldn't get the patients out of my mind. I
Okay.
kept thinking about them and going over their stories, and I would have dreams about them at night.
Wow.
And I think it would help. It helped writing it down. So I think in that way, the book was sort of therapeutic for me.
That's good. Good insight. And how did you write it? What's kind of your writing strategy? Did you
So
keep
my
contemporaneous
so my
notes?
my strategy was to do it as stories. I thought the best way to talk about the disease was to present the individual stories of the vast variety of people and their problems. And so that's what I had in my mind. I had notes on the people that I remembered that were uppermost in my mind. I jotted down notes about them. And then I actually paced back and forth in my office and simply told the stories verbally to a handheld dictating machine. So I talked the stories just as I would be talking to somebody, sitting in a pub over a beer about these fascinating people. And then I had a person type up those dictated stories, and then I edited them and embellished them and enhanced them. And that's the way the book came together.
Okay. And that explains why there's so much of the human aspect of it coming through. Um, Clearly, chorea is the most striking symptom of Huntington's disease. And I was kind of impressed by you saying it is not easy to fully describe chorea. We kind of know what it is, but it's difficult to describe. Why is it so difficult of all the movement disorders, perhaps, that chorea is such a difficult thing to tie down?
Right. I think it's difficult to describe because there isn't a single word or phrase that really captures what it's like.
Hmm.
People talk about jerks and jumps and involuntary movements, but those don't really quite capture what it's like. You really have to see somebody with the movements to appreciate what it's like. It's kind of a combination of jerks and jumps and twists and turns, and it actually varies a little bit from person to person. So I think it's a perfect example of a picture being worth 1,000 words. If you have a video of somebody with chorea, you can say, that's chorea.
Yeah.
But to write it down in words, I think is quite tricky.
And I mean, to reflect that, you described a silent movie of a person with chorea, and you said he appeared to have two different nervous systems operating in parallel, one jerky, unpredictable, and uncoordinated, and the other accurate and on target. Is this kind of typical of Huntington's chorea, or it's kind of a
I
similar
think so. I think so.
other forms of
The point,
chorea?
the point I was making was that when you see somebody with those movements, you think, "Oh my goodness,
Hmm.
they can't do anything. How are they gonna eat? How are they gonna use eating utensils? How are they gonna drink from a glass or a cup?" And yet they do. And so this video I was describing was actually taken decades ago of a man sitting in a chair with quite advanced Huntington's chorea who was smoking a cigarette. And you saw him jerking and moving around. You say, "Oh my goodness, that he just can't do that." And yet there he was, taking the cigarette out of the pack, lighting it up, putting it in his lips, taking a puff, taking it out. And he was doing it very accurately without spilling anything. And it was really quite remarkable to watch. So he had these movements, but they weren't actually interfering that much with his coordination. And that's why I said it was like he had two different kinds of brains there. One was not coordinated at all, and the other one was.
And would you say that is typical of Huntington's chorea or chorea generally? I know you try to describe two patients.
I think Korea generally is like that. I think people who have that usually are able to surprise you in what they're able to do.
Yeah. And then you talked about people with Huntington's disease who do not have chorea, which is um, how difficult does it make to make a diagnosis in such cases?
Yeah, I think that's a difficult piece to comprehend about this disease is that it was for decades it was called Huntington's chorea because that's what you see when somebody manifests the movement part of the disease. You see their movements; they're quite remarkable, and so that's how the disease got labeled. But it has become very clear that that's only the tip of the iceberg, that the disease is much more than that. That it particularly affects judgment and behavior, and those can be the most debilitating part of the disease. They can get along with the chorea surprisingly well, but when their judgment is impaired or when their behavior is impaired, that's what causes major problems for them and their families and their communities. So that's really the prominent disability in the disease. And they can manifest those behavior and mental cognitive problems without much in the way of movements. In fact, they can begin with behavior problems and not have any movements at all. So it's a misnomer sort of to call it chorea because it's much more than that.
And I suppose the chorea in the early stage was so subtle that you really need to observe to pick it up.
Right, and sometimes it's not there.
Mm.
People can have their behavior problem for years before they develop any movement problem.
And I guess if there isn't a family history, it actually even makes it more difficult to make a diagnosis.
It's very difficult. If they do not have chorea and they do not have a family history, it's usually misdiagnosed. It most commonly is diagnosed as either some kind of mental psychiatric disease or it's diagnosed as some kind of dementia,
Mm.
and it gets completely missed. And of course, because some people are adopted and because some people have parents who had late onset, it's not unusual to have someone appear who has no family history. And so that makes it very tricky to diagnose. The big advance in diagnosis that has made a huge difference was the discovery of the gene and the availability of genetic testing.
And I guess now that these tests are done as a panel, it doesn't take too much thinking, I suppose. You kind of just send for the neurodegenerative panel or something. And
Well, you have to think of it because the most of the genetic panels, for example, if you sent off a genetic panel for movement disorder, or if you sent off a genetic panel for dementia, uh, you frequently you would not find Huntington's disease because Huntington's disease is a specific kind of genetic mutation that's called a repeat expansion. And many testing panels don't test for repeat expansions. You specifically have to say, remember to check for Huntington's disease and look for repeat expansions, or it actually will be missed.
And yeah, and I think that takes us to I mean, you've talked about the experience of seeing patients as young as 5 years old and as old as 90 years. I suspect that has to do with this trinucleotide repeat problem, isn't it? Where with anticipation, the age of onset gets younger and younger. But you said this was something unique to Huntington's. Doesn't it affect, don't you see that kind of wide age spectrum with other neurodegenerative diseases? Perhaps not as young as 5.
Yeah, not so that's what I say, not that wide. Yes, there's an age spectrum of Parkinson's and Alzheimer's and ALS and FTD, but not 5 years old.
That's
You don't see a 5 or 10 year old with Alzheimer's disease or a 5 or 10 year old with Parkinson's disease. So that range
that's quite.
is quite amazing for what we consider an adult onset neurodegenerative disease. It's really quite amazing to say you've seen somebody who's 5 and somebody who's 90.
Yeah,
That doesn't happen with the other diseases.
probably, yeah. Um, and then you talked about, of course, going into the genetic testing. You talked about the genetic testing conundrum, the kind of psychological and ethical problems that come with this. What kind of message do you want to get out to readers on what are the worrying issues regarding testing for hunting?
Right. So genetic testing is actually complicated and difficult because of all the different pieces to the decisions that have to be made. At one level, it seems simple and straightforward. We've got a blood test that can tell someone whether they have inherited the mutation for this disease or not. So if one of your parents has it, you're at a 50% risk for inheriting it, and you can do a blood test and you can tell I either have inherited it or I have not. That sounds simple. But the problem is that's all the test tells you. It just tells you yes or no, you've inherited it. It doesn't tell you at what age you might develop it. Am I going to develop this when I'm 20 or am I going to develop it when I'm 30, 40, 50, 60? Test doesn't tell you that. And it doesn't tell you what kind of symptoms you're going to have. Am I going to have mostly chorea or am I going to have the behavioral problems or am I going to have both? And which is going to come first? The test gives you no idea about that. And if I do the test, particularly in the United States, for example, if you ask the question, am I going to be able to get life insurance or what's called long-term care insurance? The answer is you might not. If you have a positive test, the insurance companies will ask you whether you've had a test, and if you say yes, they won't sell you an insurance policy.
Interesting.
And so that's financially a real blow to people who are trying to prepare for a lifetime with some disability. So that's tricky business. And it also means that if your test is positive, it means that your children are at risk. And so all those permutations of the testing have to be taken carefully into consideration before you decide to test. And that's why actually large numbers of people who are at risk don't do testing because they don't want to jump into that spool of difficult permutations and combinations that they just don't want to deal with. So it's not simple than just a yes or no. It's also tricky because the test itself is not always yes or no. There's a range in the test that is a maybe. And that's tricky. The test result, the expansion can fall into a range where it says you might develop signs of Huntington's or you might not. And that's hard to comprehend when you thought it was going to be a simple yes or no.
And I guess the other issue is testing for a disease in which we don't have a cure.
Right.
Which
Exactly. There's no cure for it. There's no really good treatment for it. There are things you can do to kind of ameliorate some of the symptoms, but they're not perfect. And of course, the medications all have side effects.
And I mean, you could talk about preventative measures. We talk about that for things like Alzheimer's or Parkinson's, exercise, eat well, do all those things to kind of improve your improve your chances if you do get it. I don't think there's anything like that in Huntington's, is there? There's nothing anyone can.
Not really. I think you want to eat well and exercise. That's great. Do it. But the evidence that that's going to change the trajectory of the disease is just not there.
Okay. Clearly, the title of your book is quite striking, and it was inspired by Johnny Cooper. I'm assuming that's not his real name. And you use that case to highlight the psychiatric and legal dimensions of managing people with Huntington's disease. He was an inmate, you said, behind high, thick concrete walls of Washington State Prison. And he wrote to you asking, "Can you help me?" What was so striking about Cooper's case that had such an impact on you as to lead to the title of your book?
Well, it was early in my career, and I was surprised to be contacted by somebody who was in prison. Uh, and in fact, I wrote back to him and told him that yes, we had a clinic, so that if he was not in prison, he could come to our clinic and be seen for the disease. And what I didn't realize was that he was suffering from the disease in the prison. He was being abused and bullied by the other inmates. And he had told the warden that he had this disease, and the warden said, our prison is overcrowded. We've got people staying in the hallways, and we're way overcrowded. So, Johnny, if you can document that there's somebody who will care for your disease on the outside, we will discharge you. I didn't know that. And so he took my letter to the warden and he said, "Look at this." And the warden said, "Fine, you're out of here." And a few months later, he appeared on my doorstep, and there he was. But he was a nice guy. But it turns out that he couldn't stop stealing. He sort of had a compulsion to steal. When he was in somebody's house or when he was in a department store, he simply stole things. And that's why he was in prison. And in fact, he didn't stay out of prison very long. He broke into a home and stole again. And when they found out he was on probation, they put him right back in prison. And that raised the whole issue in my mind of, could that compulsive stealing have anything to do with his Huntington's disease? And I discussed this in some detail in the book. And my answer is yes, I think it does. It's hard, it's not a one-to-one relationship. But I think when you realize that some of the manifestations of this disease are impulsivity and poor judgment and misbehavior and agitation and anger sometimes, it's not surprising that in some people that can lead to criminal behavior of some kind. And it does, I think, more often than in the general population, although not commonly. But I think there's a tendency for some of the manifestations to fall over into that kind of behavior.
Yeah, you did say the connection is complicated and difficult to pin down. Um, was was kleptomania his only criminal tendency, or did he do other types of crime?
As far as I could tell, it was just stealing. I don't. Other than that, he seemed like a nice guy.
So it must be in the lower range of criminality. But you did mention that sadly, some of the people with Huntington's disease commit homicide, which is kind of the extreme end of.
Right. I had a patient who just was sitting watching television, and he had a gun in his pocket, and he pulled it out and shot and killed his roommate.
Ooh,
And
unprovoked.
yes, and when people asked him why, he had no explanation.
Wow.
He just he had a gun. Maybe it was what he was watching on television. I don't know. Maybe he was watching a crime show on television. I don't know. But he just pulled out the gun, shot and killed his roommate. And at that time, by the way, he was one of these people who did not have chorea. One of his patients, he was a young man, I think in his 20s.
Hmm.
Uh, he had had previous behavioral problems and run in with the police for abnormal behavior. And one of his parents had died with Huntington's disease, so we knew he was at risk. And because he shot and killed somebody, and it was very obvious that he was guilty, he went to prison. And it was years later that I was contacted by a prison psychologist who said, "I thought you'd like to know that this man has now developed chorea,
Interesting.
and would you like to see him?" And we did. And by that time, the genetic testing had become available. So
Okay.
he came to my clinic in a wheelchair from prison, and he had chorea, and we did the genetic testing, and it was positive. So it was perfectly clear that he did have the disease. In fact, he too was discharged from prison before he died because he was so disabled. They felt he didn't need to be in prison, and he needed rehabilitation kind of care outside the prison walls. So he also was discharged in the fairly advanced stages of the disease. But that, again, I think that's an example of the sometimes this manifestation of sort of aggression and loss of social control, poor judgment, and even delusions
Hmm.
uh, can lead to severe misbehavior in some of these people. Not everyone, a minority of the people, but certainly in some of them.
Interesting. And the other thing, of course, is that you wrote about people with Huntington's disease being victims of crime. I know you talked about Cooper being attacked by inmates, and some have been victims of murder. Are people with Huntington's disease more vulnerable to these kind of aggression from others than, say, people with
Yeah,
Alzheimer's?
absolutely they are, and there are numerous reasons for that. One is they often have this obvious chorea and poor coordination, and they can fall and stumble. And so when they're out in public, they're
Okay.
immediately noticed to be vulnerable because they're easy to attack. They're easy to rob, for example, and it happens to them.
Okay.
Uh, and then also they can make bad judgments. They particularly can make bad financial judgments, and so they're often taken advantage of them by financial scams. They're easy uh, uh, people for making financial mistakes and buying things and getting into financial situations that were a bad idea because their judgment is impaired. So yes, they're vulnerable for being taken advantage of both physically and emotionally and financially.
And as an extension of that, I suppose they are less likely to have the kind of families and social support that people with Alzheimer's may have, for instance.
Yeah, so the sad one of the many sad pieces of this disease is it usually hits people right in the middle of what usually is the most successful part of our lives. The average age of onset is like 42. So it's right there. If most people develop symptoms between 32 and 52,
Yeah, no.
that's the peak, earning power of your life. And that's when their lives begin to fall apart. Their judgment falls apart. They lose employment. They lose their finances. They lose their bank accounts. They have emotional problems, so they sometimes end up getting divorced. They're estranged from their families. It's quite common for people with Huntington's to be part of the homeless population in this country because they have no families, and they lose their financial support, and so they're very, very frequently very destitute.
So sad. Um, and even sadder yet, I think it's one of the cases you talked about, Tim Bennett, who had Huntington's disease and then got diagnosed with amyotrophic lateral sclerosis. You did talk earlier on about an overlap of neurodegenerative diseases. Is this one that is recognized between Huntington's and ALS, or is it just a coincidence in his case?
Well, it's unknown. It's actually an area of intense research investigation right now as we speak. Many of these neurodegenerative diseases like Alzheimer's and Parkinson's and frontotemporal dementia and ALS and Huntington's, they all seem to be the result of what are called misfolded proteins. So amyloid or tau or TDP-43 or Huntington, they're proteins in the brain, and they're misfolded in some way, and they aggregate, and that apparently disturbs the normal chemical pathways within the cell. So they all have that in common, although they're different proteins. So, but the reason for the misfolding may be similar in them, and so there may be some kinds of overlap. And one of the questions is, for example, is there an overlap between ALS and Huntington's? There are people that think there may be. That has not yet been established. We actually wrote a paper on people with a bunch of people we had with Huntington's who became quite demented, and when they died, we were able to do brain autopsies on them. And in addition to Huntington's, they had Alzheimer's disease. So we raised the issue of, is there an overlap? Are people with Huntington's more apt to get Alzheimer's? And it may have just been their age. I don't know. But so there are possible connections between these diseases, but they haven't been clarified yet. It's still part of ongoing research.
And I know there's a lot of talk about the prion-like hypothesis behind a lot of these neurodegenerative diseases. Um, I guess Huntington's would feature if that becomes an established route to these neurodegenerative illnesses.
Yes, it's one of the issues, how do these diseases spread within the brain from neuron to neuron or astrocyte to astrocyte? And there's evidence in all of these diseases that there is some spread of the abnormality within the brain, and that's a fascinating issue, but it's still being investigated.
And of course, apart from the chorea and the cognitive symptoms, the large part of Huntington's disease are the psychiatric aspects. And you talked about it under a chapter titled Delusions, Hallucinations, and Diabolical Possession. And many of the anecdotes were quite striking. One that caught my attention was Herman Benson, who believed that the devil had taken up residence inside his body and was telling him to injure other people. Could that explain some of these episodes of violence that the people with Huntington's might carry out?
Yes, I think so. That's the overlap of Huntington's with schizophrenia.
Mhm.
And it's the overlap of both of those diseases with another condition called frontotemporal dementia. They have serious psychiatric manifestations, and it can include delusions and hallucinations, and that happens in Huntington's. There, people, neurologists argue about how common is that. I think it's at least 5% of people with Huntington's have these severe psychotic kinds of manifestations, which include delusions and hallucinations. And when they're hallucinations, they're usually auditory, not visual. In another condition called Lewy body dementia, they get hallucinations, but they're usually visual. In Huntington's, they're usually auditory. And Benson, Mr. Benson, that I talk about in the book, had auditory hallucinations. It's the kind of thing you read about in schizophrenia, but here it is in Huntington's. He thought the devil was inside his body somewhere and was talking to him and was telling him to do bad things, to hurt other people. And he was either divorced or widowed, and he was living with his sister.
Okay.
And he started throwing furniture around the house and started threatening her. And she became very frightened. She called the police. He went to jail. And then he got transferred to the inpatient psychiatry ward where they put him on schizophrenic antipsychotic medication. And that calmed him down. And he stopped being violent and accusatory toward his sister. But when we talked to him, he would tell you that he still heard the voice,
Okay.
but it didn't bother him as much. So I think the medication was helping, but it was helping in an unusual way. It was just sort of tamping down the problem, but the problem didn't go away, but it was less serious and less severe. So the medication helped, but it didn't, it wasn't curing the disease. So it was quite strange. And I think that same thing happens in schizophrenia. The people are treated, they calm down, their delusions and hallucinations aren't as severe, but they don't go away, and it's not curing the disease.
I suppose the medicines are probably also giving them some insight into these hallucinations being not real, I suppose.
I'm not sure about that. I think he may still have thought they were real. They just didn't bother him as much.
Then there was another patient, Jason, who also thought he was possessed by the devil. Is
Yeah.
this devil possession a kind of a distinctive psychotic feature of Huntington's, or is it just
No, no,
coincidental,
I think it's a distinctive feature of psychosis.
but not of psychosis of Huntington's?
No, I think, schizophrenics can have the same kind of delusions, and so can people with frontotemporal dementia. I think in all probably in other cultures too. People, there are boogeymen, there are bad spirits in all cultures, and when people become seriously mentally ill and delusional, they think about those bad spirits and they feel they're being possessed by those bad spirits. And I think that's probably cross-cultural. I suspect that all schizophrenia-like individuals in any culture will internalize the bad spirits that get talked about in their culture.
Um, then the other thing you talked about was the tendency of people with Huntington's disease to be involved in traumatic events. And this was not just because of their chorea. What else predisposes people with Huntington's to accidents?
Well, it's two things. One is their poor coordination. They have a tendency to fall. Uh, and in another one that we have actually written a recent paper about is because they have a tendency to fall and because they have a tendency to jerk around, they hit their head.
Okay.
And we've had a surprising number of Huntington's people who have had subdural hematomas because they've fallen and hit their head, or they've been sitting in a chair and banged their head against the wall. And so subdural hematoma is a well-known complication of Huntington's because of the falls and the poor coordination they have. And then the other element in that is their poor judgment.
Okay.
They will do things that you wouldn't ordinarily do. I had a man with Huntington's who was being driven around in a car, and all of a sudden, out of the blue, he just opened the car door and fell out.
Yeah.
And, just bad judgment,
Wow.
and got, you know, hit his head and broke a number of bones and was almost killed just because he suddenly did something very strange and bizarre and was indicated poor judgment.
It's all very frontal lobic. Um,
Yes. Yeah.
okay. I mean, for me, probably the most heart-wrenching aspect of Huntington's disease we talked about is the manifestation in children. Did your clinic involve pediatrics as well? Did you see pediatric patients, or did you have a
Uh,
specific?
We didn't, we weren't geared to do pediatrics, but we were consulted on pediatric cases because the local pediatrician wasn't sure. They would have a child whose parent had Huntington's, and they were trying to sort out, was this child manifesting the disease or not?
Yeah.
And so they would be seen in our clinic to give some advice and to examine the child. Is this child showing signs of the disease? And so we would see children, usually not, we wouldn't follow them, but we'd see them once or twice in the clinic. So I've had quite a bit of experience with juvenile cases as well. And of course, it's very sad because, to have a 7 or 8 year old manifesting this disease is very unfortunate. And it's a bit different from the adult disease in several ways. One is they tend to present with the motor physical problems, but it's usually not chorea. It's often even either ataxia, poor coordination of walking, or dystonia, stiff, rigid muscles. And then in this particularly early onset, if onset is before the age of 10, they have a much higher likelihood of having seizures.
Okay.
And that's actually unusual in adults with Huntington's.
Okay.
And then the disease is more rapidly progressive in children. Huntington's usually live with symptoms for 15 to 20 years as adults, whereas in children, they rarely live more than 10 years. The average age of the disease in children is like 8 years. So if you have somebody who manifests when they're 8, they usually die by the time they're a teenager. So it's very sad.
And I guess that's to do with the length of the trinucleotide repeats, is it? The younger they are, the longer the.
Yes, it's definitely associated with that. And in fact, at the end of my book, I have a chapter describing the trinucleotide repeats and the different sizes and the fact that the longer, larger the repeat, the earlier the age of onset, and the children often have extremely large repeats, and that clearly has something to do with why they have such early onset. Although exactly how is not clear at all biologically.
Yeah, sad disease. It's difficult to think of any aspect of life actually that Huntington's disease doesn't impact. You talked about marriage, family, employment, driving, and of course the stigma. How would you advise society or your readers to kind of relate to people with Huntington's disease?
So one thing is to understand it, to realize that when somebody has the disease, that they have a disease, and they're not responsible for their movements that they're having. That can be uncomfortable for people around them. In fact, it's more uncomfortable for the people around them than it is for the patient. They get along fine with their chorea, but it can be very uncomfortable for people sitting around them. So understand that they're not responsible for that, and it doesn't mean they're dangerous in some way. And the same with the psychiatric manifestations. If they're misbehaving, if they're doing peculiar things, if they're making bad decisions, it's not because they're, a quote, bad person. It's because they have a brain disease, and that has to be taken into consideration. It's the same way you would think about somebody with Alzheimer's disease or somebody with Parkinson's disease. They're not responsible for their movements or for their behavior. You have to understand that. And then, I used the three terms at the end of my book. I said that it requires compassion. You need to have empathy and compassion for these people. You need to be determined to help them and be in for the long haul. This disease is going to go on for years. So you also have to have patience. They have their ups and downs, their good days and their bad days, and you have to have a lot of patience for that. And it's important for society to also, think about how do you care for these people if they have no finances and they have no family support.
Yeah.
How are we going to care for them? To have them live in a cardboard box under a bridge is not the solution. We need to have a better kind of community support for such individuals. I have couple of chapters in there about the big old psychiatric asylums that people used to be put into, and that turned out not to be a good answer.
Mm.
But it was primarily not a good answer because they weren't well funded and they weren't well uh, uh, established with personnel. So it takes a lot of money and a lot of trained people to care for these individuals, and we need to have uh, centers where they can be seen frequently, and if they can't care for themselves, they need to be taken care of. Maybe for a short term, for a month or two, but in some cases, maybe for a few years. But our communities need to do a better job of caring for these individuals who financially and behaviorally can no longer care for themselves.
And I guess Huntington's is not in the Goldilocks zone of getting a lot of research funding and big charities behind it and loads
Well,
of.
it has some, because of its, I think because of its overlap with other more common diseases like Parkinson's and Alzheimer's, there certainly is funding for it. It
Okay.
needs more, but there is funding, and most countries actually have some kind of philanthropy for
Okay.
Huntington. The United States has an organization called the Huntington's Disease Society of America, and it funds centers all over the country. Almost every state has a center funded. It's not heavily funded, but at least it provides some support. And Europe, for example, has the European Huntington's Disease Network, and that's a community of both clinicians and investigators who are studying Huntington's disease and focused on Huntington's disease. And Japan and Australia, New Zealand have the same kind of thing. So there is some financial support for Huntington's worldwide, but it clearly is not enough.
And research for finding a cure, is a cure anywhere near the horizon? I know we give tetrabenazine and such symptomatic treatments. What are the prospects? Cure is a big word to use in neurodegeneration, but any prospects at all? Cutting
There
edge?
are there are prospects. What has been learned about the disease in the last 30 years is quite amazing. So, my career has covered that whole era
Mm.
of knowing almost nothing about the disease to knowing a lot about the disease, about what part of the brain is affected, what cells are affected, what the genetic cause seems to be. So a lot has been learned about the disease, and all of those pieces of information have led to ideas about treatment, both better treatments and also some kind of prevention or even cure for the disease. And so there's a lot of enthusiasm and optimism about getting much better treatments and preventions for the disease. But the optimism has to be tempered with the fact that it's difficult, it's complex work, and it's going to take time. There actually have been attempts to treat the gene to try and shut down the effects of the gene within the body, within the brain, by injecting gene controlling chemicals into the spinal fluid through lumbar punctures, through spinal taps, and having that get into the brain. And there was a great enthusiasm that was going to work a few years ago, but the major study doing that was negative. It didn't work, but that people haven't given up their ideas to improve the approach, make it better, try to make it more effective. So there is optimism. There are people working on it, but it's not going to happen overnight. It's going to take years.
Well, it gives hope to victims and their families.
That's right. There definitely is hope.
Well, I mean, like most other diseases of the brain, we kind of management is mainly focused around care. One of the strategies you talked about, the coping strategy, was to enjoy the moment. How does somebody with Huntington's, with all the depression, risk of suicide, how do they kind of focus on the moment. Is it possible?
So it absolutely is possible, and I give examples of that in my book. And I don't think we can make it happen. I think it tends to be the personalities of the individuals who have developed the disease. I mean, they've got this disease, but they also have their own individual personalities. And there are people who are, I think they're natural optimists, which is great. And I've seen a number of individuals with the disease who they're just natural optimists. And they say, yes, I've got this disease, but so what? I can carry on my life. There are things I can do. There are people I love and admire. I have friends and family. I'm going to enjoy my life. And they do. They have a sense of humor. They get out and around, and it's really quite remarkable to see people do that. And of course, that happen. You see that happen with ALS. You see that happen with Parkinson's. People, they just seem to have the right attitude, and they don't let the disease get them down. And it's wonderful to see that happen.
Okay. Well, from that, the take home message for me is kind of not to single it out among the other conditions in terms of kind of how you care and
Right. And I also have I have a chapter in there of all the people that I've seen who, for example, have had very successful careers.
Hmm.
You know, they've been musicians, they've been teachers, they've been professors, they've been business persons, they've been lawyers, they've been scientists. They've had very successful careers because you have to remember that sometimes you don't develop symptoms of Huntington's until you're in your 50s or 60s. So that allows you decades of actually having a very successful life, successful career, and that's happened to a lot of people. And so that piece of the disease should not be forgotten.
That's reassuring. It's not all doom and gloom. Um, you talked about treating more than 1,000 people with Huntington disease over your career, and you did mention having sleepless nights thinking about the patients. How have you yourself coped with the emotional impact of caring for people with this distressing and incurable disease?
Right. Well, one of the ways, as I mentioned, was I wrote this book, and that actually helped me a lot.
Mhm.
One of the other most useful ways is to have a team that's caring for these people. So I didn't do it alone. I had genetic counselors, and I had nurses, and I had social workers. So we had a team that helped a lot. It helped in caring for the people because they all had expertise that they could bring to bear on the patient's problems. A really good social worker can do more for a patient than a doctor can, I think. Uh, and we were able to discuss the cases. So we could sit down around a table with a cup of coffee and talk about these people and talk about what we could do for them, how it was influencing us, and actually sort of group psychotherapy. And that helped a lot.
So kind of peer group support. Um, like
Right.
there's something Schwartz did, wasn't it? Kind of create a space for people to talk about the impact of the patients they see on themselves, talk it out and kind of release the pressure, emotional
Right.
pressure.
I think that helps a lot. And you know, some of the things that happen to these people, on the one hand, it's kind of sad and unfortunate, but on the other hand, we would sit around and we'd shake our heads and laugh about it
Hmm.
because what had happened to them, you know, a serious aspect to it, but also sometimes had a humorous
Yeah.
aspect. You know, I talk about the lady in there, one of the optimistic people who she had what she called the Huntington's greeting. And so,
Okay.
you know, when you greet somebody,
Yes.
you slap hands like that. And she'd say hello to me. And then so I'd say hello and we'd go like that. And she'd purposely move her hand and miss. And she'd laugh and say, that's my Huntington's greeting. And so, you know, she was bringing humor into her life from having this disease. And so that allowed the group of us to laugh with her about those kinds of things.
That's great. Okay, we've talked a lot about the lessons from your book. I have learned a lot. Are there any specific lessons you kind of want to, we haven't talked about, or you want your readers to kind of take away from the book?
No, I think it's learning about diseases like this. I think they're absolutely fascinating, and recognizing that there are people out in the community who have these diseases, and we need to relate to them and help them and have compassion for them. At the same time, realizing that we all have brains, and all of our brains have problems. We all forget things. We all make mistakes. We all do dumb things. We all have coordination problems, especially as we get older. And so, it's part of life, and we need to come to an understanding of that.
We've talked about what the future holds already. What do you think is the biggest uncertainty about Huntington's disease,
So
scientifically?
the big uncertainty is whether an effective treatment or preventive will be found in the next few years. No one really knows. It would be nice, if 5 years from now we could say we've got a much better treatment for the disease. I would like to see that happen, but we don't know. We're just going to have to. The investigators are going to have to keep working on it, and we keep our fingers crossed and hope that it happens.
Hope for the best. Um, have you written any other books, or are you planning to write?
No,
That's it.
that's it. That's my book.
Okay. That puts a lot of weight on it. Are you
Yeah.
any project? I know you're an emeritus professor. Are you involved in any projects at the moment?
Yes, no, I don't see patients anymore, but I'm still involved with research of neurodegenerative diseases. I have some projects on Huntington's disease that I'm helping other people with. I have a project on Alzheimer's disease. I have a project on frontotemporal dementia. So I'm still involved in research on genetic neurodegenerative diseases. There's a genetic form of Alzheimer's, and there's a genetic form of frontotemporal dementia. So I work on all of those.
Yeah. You've kind of spread your wings a bit beyond.
Right,
Okay.
right,
Um,
exactly.
well, final question. Any books you want to recommend to my listeners or to myself?
There are a lot of books. I could come up with a very long list.
Yes.
Uh,
Of
if
them.
you limited me to three, the three I jotted down was one. There's one called Inside the Robinsons, and
Okay.
that's written by a person named Lisa Genova. And it's a novel, but it's about a family with Huntington's disease.
Okay.
She wrote a very famous novel about Alzheimer's disease that was made into a movie that got an Academy Award. And so she went on and she's written one about Huntington's, and that's called Inside the Robinsons.
Okay.
And then I would also recommend one by uh, Atul Gawande, Gawande, called Being Mortal.
Okay.
And he's an internist, he's a physician, and it's mostly about him relating to his father, who was growing old and developing lots of different kinds of disabilities, and the family and the physician's son having to come to grips with his father growing old and developing various kinds of disabilities. And I think it's very well done.
Interesting. Okay.
And then another one that I found quite interesting was one called The Center Cannot Hold.
Okay.
That's by a person named Ellen Sachs, Saks. Uh, and it was written quite a few years ago, but it's about her experience with schizophrenia.
Okay.
So she's actually a professor at one of the universities in California,
Okay.
uh, and she has schizophrenia,
Okay.
and she has a lot of insight about it. And so she's actually written a book about her experience dealing with her own schizophrenia and the delusions and the hallucinations and the psychiatrists that she's seen and the medication she has to take and the side effects. And One of the interesting points she makes is that people who take medication that works feel better. Then when they feel better, they decide they don't need the medication anymore. So they stop taking it and then they fall apart again. And that's sort of a vicious circle that people with these diseases get into. And I see that all the time with Huntington's. You give them a medication, they feel a lot better, they're doing better, and they say, "Well, I don't need medication anymore." They don't take it, and then they get worse again. And she very nicely, she has insight about having that happen to her. So that's called the center cannot hold.
I was mulling the idea of doing a podcast on schizophrenia. So I might look that up, and a bit outside the neurologist sphere, but it's still the brain. So I might consider that.
Absolutely. Well, and that's one of the controversies that you keep constantly run into with these diseases is, I have people with Huntington's who have severe behavior problems. And sometimes you try to get a psychiatrist to see them, and they say, no, it's not a psychiatric disease. It's a neurologic disease. I can't deal with it. It's a brain disease. And I say, well, schizophrenia is a brain disease.
As well, yeah.
And then sometimes the opposite happens. You have people with Huntington's who have severe emotional and uh, behavior problems, and you try to get them seen by a neurologist, and the neurologist says, "That's not what I do. I don't take care of people with behavior problems. They need to see a psychiatrist." And people forget that these are all brain diseases. They're manifesting in different ways.
The wall between psychiatry and neurology, I suspect we're going to have to bring it down at some time in the future.
Yeah, there's huge overlap, and as you said, it's all the brain.
It's all the brain. It's all the brain. Interesting. Yeah, and you mentioned Atuga one day. I have to say, it's his other book called the Checklist Manifesto that led me to develop my own website called Neurochecklist, because he advised every physician to develop checklist for everything we do, because it's so easy to get things wrong. So I'm
Yeah,
glad you mentioned his book, and yeah, he is one of my inspirations.
yeah, he's a great guy.
Thomas Bird, thank you very much for participating in this episode of the Neurology Lounge podcast. I've really enjoyed it and I've learned quite a lot. And to my audience, thank you for watching or listening to the program. If you enjoyed it and found it enlightening, why not have a look at my checklist, neuro checklist? And I've also written a small book called Surfing the Brain. You might find some interesting anecdotes there. And to make sure you don't miss the next episode of the Neurology Lounge podcast, you might subscribe to the iTunes, Spotify, or YouTube channels of the podcast. Thomas, but thank you very much, and I'm very grateful.
If they're interested in Huntington's, they might want to buy my book.
Yes, and that's why it's one of the books I featured. I hope they will. I've enjoyed the book thoroughly, very well.
It's been my pleasure.
Same here. Thank you.